So I'm going to go over the top 10 vasopressor articles that you need to know for 2026, basically. These are the top 10 either historical articles or current articles. So the VASST trial with vasopressin and norepinephrine, then the SOAP2 trial with levofed versus dopamine, SEPSISPAM knowing the target, MAP 65 versus 75. Then the VANISH trial 2016, again, vasopressin plus steroids plus or minus steroids versus levofed plus or minus steroids. Then the ATHOS-3 trial, which was the angiotensin II rescue, geopressin. Then the sensor early norepinephrine trial, adrenal and aprocus trials looking at steroids in septic shock, and then the ANDROMEDA trials, ANDROMEDA-SHOCK 1 and 2, looking at cap refill versus just regular lactic acid clearance, and then the CLOVERS trial that would round out the top 10. And then historically, just to know about the epinephrine versus norepinephrine 2008 trial, as well as the Zygris Prowess 1 and 2 trials. So the bottom line is modern septic shock care is early norepinephrine, conservative fluids, and perfusion-guided decisions to avoid over-resuscitation. So first we'll talk about the VASST trial in 2008. Vasopressin and norepinephrine, randomized 778 septic shock patients on norepinephrine to vasopressin 0.01 to 0.03 units per minute, was not titrated. It was basically set at that level. Versus norepinephrine alone, there was no overall mortality benefit, and there was a signal in less severe septic shock, norepinephrine less than 15 mics per minute. Vasopressin reduced catecholamine dose, and it established as a norepinephrine sparing adjunct. So the key to this trial is that there was a predefined subgroup of less severe septic shock. So that's better than a post hoc analysis. It was actually a predefined subgroup of less severe septic shock, and it seemed to show that there was a mortality benefit of vasopressin. So clinically, if you have a patient who's, let's say, on 15 mics of levofed, your next choice, would it be going up to 20 mics of levofed if they're in septic shock, or adding vasopressin? The answer would be, according to the VASST trial, it would seem that there would be a benefit in adding vasopressin. The second trial is the SOAP2 study, 2010, norepinephrine versus dopamine, SOAP2 trial. 1,679 patients with shock, norepinephrine versus dopamine, similar mortality. So it did not show a better mortality with levofed, even though levofed is the drug of choice in septic shock, but dopamine caused more arrhythmias. The number I want you to remember is 24% versus 12%. This also reminds you that you can say that 12% of the time when you use levofed for septic shock, it's going to cause an arrhythmia. That would be like atrial fibrillation. And there were worse outcomes in cardiogenic shock, surprisingly, with dopamine versus levofed. So norepinephrine took over as the first-line vasopressor in septic shock. The third trial is SEPSISPAM. SEPSISPAM looked at a MAP of 65 versus 75 versus 80 to 85, 65 to 70 versus 80 to 85. There was no mortality benefit. The higher MAP actually showed higher, more atrial fibrillation. The CKD group, subgroup, had less RRT. That means actually the patients who were chronically hypertensive at baseline did better in terms of having a higher MAP versus lower MAP. But in general, your target should be 65 based on the SEPSISPAM trial in 2014, again published in the New England Journal of Medicine. The next trial, VANISH trial, it was also published in the New England Journal of Medicine, 409 patients. That's vasopressin versus levofed plus or minus hydrocortisone. No mortality or renal benefit, and it confirmed vasopressin's catecholamine sparing role, not outcome changing. Like the VASST trial, there wasn't a big overall mortality benefit, but it did show that you could be on less levofed if you were on vasopressin. The next trials to remember is the ATHOS-3 in 2017, angiotensin II. So if you're on 3 pressors and you're in vasodilatory refractory shock, angiotensin II was proven to improve MAP response, again published in the New England Journal of Medicine, 70% versus 23%. What's interesting is that the placebo increased blood pressure by 23%, but there was no mortality benefit. Angiotensin II is very expensive. I think it's like $20,000 per vial, however much a vial is. But that is a positive trial in terms of MAP response. Then came the sensor or early norepinephrine trial. Early norepinephrine in emergency room septic shock improved shock control and reduced fluids. 76% had improved compared to 48% who were not given early norepinephrine. It supported the early vasopressors alongside, not after fluids. So this was a shift in fluids, then pressors. Now it was pressors along with fluids. That was the sensor early norepinephrine trial. The 2 steroid trials that you should know of are the adrenal trial, 3,600 patients plus hydrocortisone versus placebo. There was no mortality benefit, but faster shock reversal and fewer vasopressor days. So this comes on the heels of the prior corticus trial, which was negative, but it was mostly surgical ICU type of patients. This was a medical ICU type of patient population. The aprocus trial was a positive mortality benefit, showing positive mortality benefit, hydrocortisone and fludrocortisone. So if you're giving it specifically evidence-based, you should probably give it the way the aprocus trial had it, hydrocortisone plus fludrocortisone, 1,241 patients. The combo of the steroids reduced 90-day mortality, number needed to treat was 17, sped the shock resolution, and that's the story. And so the last couple of trials, so the ANDROMEDA program, so the first ANDROMEDA-SHOCK trial, and the ANDROMEDA-SHOCK trial 2, very important trials. 2019, capillary refill guided versus lactate guided resuscitation. So typically like lactic acid clearance would be one way to know if your septic shock is getting better. So like, let's say your lactic acid was 5, and to show improvement, it would be a 10% improvement by 2 hours, or a 20% improvement, some would say. 10% of 5 is 0.5, right? So if you went from 5 to 4.5, that would be a lactic acid improvement. But how about cap refill? So you would check cap refill, you would hold it for 10 seconds, and then you would check to see if it's less than 3 seconds cap refill. You would put your index finger there, hold it for 10 seconds, then you would see less than 3 seconds or more than 3 seconds. And they showed basically that there was a mortality trend if you used cap refill versus lactic acid. So the point is that your lactic acid still could be elevated, and you could have a good cap refill, and you're just giving too much fluid and more pressors when it's not needed. So it turns out that they repeated the study in 2025 with 1,500 patients. The first study had 424 patients, and they looked at mortality and organ support and length of stay. There was an improvement in that hierarchical outcome, but it wasn't just a solid mortality benefit. There was less organ support. And so CRT becomes a gatekeeper. Perfusion is normal. Stop resuscitation even if lactate remains. Elevated focus moves to avoiding over-resuscitation and iatrogenic harm. Then the CLOVERS trial in 2023 showed that restricted fluids and early pressors are the way to go. Early levophed was looked at liberal fluids. There was no mortality benefit, no difference, 14 versus 14.9%, but less fluid exposure in the early levophed. It confirmed the safety of early pressors and fluid restraint. I would like to discuss epinephrine versus norepinephrine as an honorary mention. It's not top 10. Epinephrine was looked at against levophed plus dobutamine, and there was similar map and mortality. Epinephrine, however, did cause transient hyperlactemia, and again, it causes clamping down on the splanchnic circulation, so probably would not be the best choice in abdominal sepsis. And of course, lactic acid would not be reliable when you're using epinephrine drips. Prowess trials, there was Prowess 1 and Prowess-SHOCK trials. Prowess trial historically showed a benefit with activated protein C. The number needed to treat or help was actually 16, which was an amazing number needed to treat. But the Prowess-SHOCK trial showed that the number needed to harm was something like 40 or so. And it's important understanding this historically that you'll see a positive trial followed by a negative trial, just because the positive trial might have been in a specific subgroup of patients and it probably wasn't randomized too well. It's hard to understand why one trial would be so positive and then the next trial would be negative. But the modern septic shock care should be early norepinephrine, conservative fluids, perfusion-guided, and it should avoid over-resuscitation. So in summary, to review, the 10 probably key vasopressor trials in the ICU would be the VASST trial in 2008, vasopressin, probably beneficial in less septic shock versus norepinephrine. SOAP2, levophed, better than dopamine in terms of arrhythmogenic, and actually better in cardiogenic shock, surprisingly, but no clear mortality. SEPSISPAM, basically showing for the majority of patients, MAP of 65, is fine, except for your chronically hypertensive patients. VANISH trial really showing that there's no clear benefit vasopressin versus levophed, although the vasopressin could get you off of the high dose levophed, which might be a problem. ATHOS 3 trial showed benefit of angiotensin II in terms of blood pressure, but not in terms of mortality. SENSOR trial was the first one showing early levophed could probably stop you from using a lot of fluids. The adrenal trial showed steroids helped in shock resolution, but the APROCHUS trial showed that there was a mortality benefit, and remember, fludrocortisone was added to hydrocortisone. ANDROMEDA-SHOCK and the ANDROMEDA-SHOCK 2 trial basically showing that capillary refill is the way to follow up patients even better than, or at least as good as, lactic acid clearance. CLOVERS trial showed you that early levophed has a role in, or at least it's just as good as liberal fluids. You should know epinephrine versus norepinephrine. Prowess trials historically, but modern septic shock care is early norepinephrine, conservative fluids.